Good morning. I'm Thomas Lazzarini, one of the first-year residents. My faculty discussant is Dr. Berrocal, and the title of the talk is Worth a Second Look. No financial disclosures, but this talk will involve the use of off-label or investigational medications. The case presentation is a 4-year-old boy with no medical history who tells his mother he's having difficulty seeing out of the right eye. He presented to the emergency room. As far as his ocular history, he had a recent visit for a KED in the left eye. The exam was documented as normal with a limited exam of both eyes. Otherwise, he's developmentally normal with no known neurologic deficits. As far as his examination, visual acuity was 20/40 in the right eye, 20/30 in the left eye, though nursing documented the patient was poorly cooperative with the evaluation. Otherwise, the pupils were round, reactive, no APD was noted, and the exam was otherwise normal. Can one of my fellow residents describe the photos?
Dr. Russell, for not reminding Dr. Henkel to get the uniforms.
So these are external, likely EUA photographs of the right and left eye, and everything is within normal limits. I can't really comment on a red reflex, but I don't see any frank leukocoria.
Yep, exactly. So the examination externally was normal, including the anterior chamber. And the posterior?
So these are Claris photographs of the right and left eye. Starting with the right eye, we have a clear view in. The disc looks normal. The vessels appear largely normal other than in the supratemporal periphery. We can see what look to be maybe aneurysmal or telangiectatic changes. I don't appreciate those changes in the nasal or superior quadrants. Attention is drawn to the periphery, most pronounced off the inferior arcade, and then the superior and nasal periphery. We see extensive exudation. Not really any hemorrhages, except for maybe some temporally. And then there's a little bit of exudation just within the superior macula. The fovea itself looks normal. And then in the left eye, we have a completely normal exam.
Yeah, perfect. So the right eye, major findings were the vascular changes in the supratemporal periphery, including telangiectatic and aneurysmal changes, and then the exudation predominantly in the mid-periphery. Left eye was indeed normal. So do we have a differential diagnosis for this?
So we have a young, healthy 4-year-old boy with mildly decreased vision and retinal vascular changes and exudation unilateral. I think 1, 2, and 3 on your differential are Coates disease. Other things that you could entertain, it doesn't look like retinoblastoma, but you always have to think about it and rule it out. You could entertain a diagnosis of ROP or fever, but it doesn't really appear like that on examination. You always have to think about Coates-like responses, which you can see in things like RP, pars planitis, uveitis, retinal-capillary hemangioblastoma, etc. But really, the FA would clinch the diagnosis here for Coates disease.
Yeah, exactly. So always need to consider retinoblastoma, but likely to be a vascular condition, including Coates disease, as well as need to consider some infectious and possibly genetic conditions. So apart from a complete family history, which was negative for any retinovascular or retinal conditions, review systems, which was negative, you mentioned FA. Any other imaging you would want for this case?
Well, since the child's under EUA, you'll probably get everything, but I think you probably don't really need it.
Yeah, so we went ahead and got OCT, FA, and ultrasound. So these are the OCT cuts through the fovea. Limited image quality on the right, but we have preserved foveal contour with no exudation or and preserved retinal layers. The left is normal as well. We got OCT through one of the exudative lesions, which shows exudation within the retina, as well as thickening and irregularity within the retina at that area. Would you like to describe the fluorescein angiography?
Sure. So this is a wide field FA of the right eye. This is an early phase examination, and at this phase of the study and with this field of view, it looks pretty normal.
Okay.
And now we see out in the temporal periphery, we see areas of telangiectasia, looks like some small aneurysmal changes, some capillary dropout, and then late leakage. And the left eye is normal.
Exactly. We went ahead and got a B scan as well, mostly notable for not having any calcification and no masses on the B scan. Of note, the axial length was different in both eyes, suggestive of anisometropia. So as you suggested in the beginning, we narrowed the diagnosis down with presumptive diagnosis of Coates disease. So this talk will go over the history, epidemiology of Coates disease, pathophysiology of the disease, as well as disease classification, clinical features that can help differentiate Coates from retinoblastoma, as well as a discussion on the current management of Coates disease at various stages. So Coates was initially described by Dr. George Coates in 1908. He had a case series, and he defined the disease as a unilateral disease of young males with exudation with or without vascular changes, without a clear inheritance pattern. As far as epidemiology, it's approximately 1 in a million people are affected by this disease. Predilection for males usually presents early in life with earlier presentations, often in more aggressive forms of the disease. Most cases are unilateral, and a lot of bilateral cases involve misdiagnosis of either systemic or genetic conditions that are later discovered. Majority of patients present with decreased vision on initial presentation in the affected eye. In young children, typical presentation can involve leukocoria or strabismus. In adults, it will either be picked up on routine examination or sometimes with reduced vision as the exudation progresses. The pathophysiology of Coates is thought to involve defect in mid-capillary angiogenesis, in which there's a breakdown of the blood-retinal barrier. Plasma infiltrates the vessel walls, leading to wall thickening, vessel degeneration, and aneurysm formation. This leads to peripheral ischemia, as was seen with the sectoral ischemia on the fluorescein angiogram. And this results in the release of many growth factors, including VEGF. These electron micrographs show the thickened vessel walls. On the top, there's still some normal endothelium, but infiltration within the vessel wall. And in the bottom photograph, complete loss of endothelial cells and pericytes, which is the process through which the vessels degrade. These are some typical findings seen in Coates. So similar to our patient, this is a peripheral image showing telangiectatic and aneurysmal changes with the characteristic light bulb aneurysms on the angiography. This is a photograph that shows the typical golden exudation. The exudation is typically found in the mid periphery and has again a predilection for the fovea as well. There's also an early serous retinal detachment along the inferior arcade. As this disease progresses, it's characterized by massive exudation, which can lead to total retinal detachment. And there can be some late consequences, including total retinal detachment, neovascular glaucoma, and in rare instances, anterior chamber cholesterolosis. These are some pathology slides showing some of the characteristic findings in the histopathology. So these are the dilated intraretinal vascular vessels. The cholesterol slits within an area of nodular proliferation of the RPE. And a study was performed that showed a correlation between the levels of vascular endothelial growth factor in the anterior chamber with increasing amounts of exudation. So on the x-axis is the extent of the exudative retinal detachment, and the y-axis is the level of VEGF found in the anterior chamber. The classification of Coates really follows this progression. So the stage 1 Coates just has vascular abnormalities, whereas stage 2 involves exudation, with 2A involving extrafoveal exudation, 2B involving foveal exudation. And of note, when there's foveal exudation, if there's nodular exudation under the fovea, it portends a poor visual prognosis even with treatment. Stage 3 involves subtotal and then total retinal detachment. In stage 4, you have a total retinal detachment with secondary neovascular glaucoma, and stage 5 is end-stage disease, often with a tisical eye. Based on our patient's presentation with telangiectasia aneurysm in the periphery, as well as extrafoveal exudation, he would be classified as stage 2A coats, which portends a good visual outcome for our patient. The goals of management of coats, initially, again, it's a diagnosis of exclusion, so you need to really thoroughly evaluate the patient to exclude alternative diagnoses. In young patients particularly, you need to make sure that you're not missing a retinoblastoma. The management typically involves angiography-guided photocoagulation of the abnormal vasculature, frequently currently with adjuvant anti-VEGF, which is an off-label use of bevacizumab. And then vitreoretinal surgery is usually deferred only when necessary to salvage the globe, and then close monitoring for progression. So here is a discussion on how to differentiate between Coats disease and retinoblastoma. In our case, we have an early stage of Coats. There's clearly no mass seen, no retinal detachment, so it's a bit of an easier distinction. But in a lot of cases of more advanced Coats, it's a very important and sometimes difficult distinction to make. But there are some characteristic fluorescein angiography findings that you can find in diffuse retinoblastoma where there's not the typical mass that would tip you off. You can look for tortuous vessels, dilated feeding vessels in the area of the mass, complex branching and telangiectasia within the area of the tumor, and then importantly, where these arrows are on the left side image, you can have early termination of vessels as they enter a mass within the retina. And then in Coats disease, you get primarily peripheral changes. You don't have any dilated feeder vessels typically, and the vessels are visible throughout their course as they stay within the level of the retina. Calcification is a very important topic because it's usually something that people can use to differentiate between Coats disease and retinoblastoma. As in retinoblastoma, you'll see characteristically calcification within the lesions, and in Coats there's usually not calcification. There are some important exceptions to be aware of. This is a case from Dr. DeBovie that shows intraretinal calcifications on the left, a B scan showing both subretinal and intraretinal calcifications at those arrows. The patient developed a blind, painful eye and so underwent enucleation. So there's the gross specimen showing total retinal detachment with massive exudation. Which allowed for pathological studies which show nodular proliferation of the RPE and then osseous metaplasia in that area. In Coats disease, if you see calcification, it's most likely going to be subretinal and involve areas of osseous metaplasia, but infrequently you can also get intraretinal calcification, which can lead to some confusion. Yeah, so just to be aware of, you can get some dystrophic calcification in areas of very abnormal retina. So this slide just summarizes some of the key findings that you'll find in Coats disease versus retinoblastoma. Retinoblastoma tends to present at a younger age. It doesn't have any sex differentiation seen. In Coats, it's almost always unilateral, whereas 40% of retinoblastoma will present with a bilateral disease. There's generally no family history in Coats. The vitreous is almost always clear, whereas you can have clumps of white cells in many cases of retinoblastoma. There's no mass in the vast majority of cases of Coats, and then the fluorescein angiographic and ultrasound features are also listed in the chart. So the management of early stage Coats, such as our patient, involves getting a good examination, including fluorescein angiogram, frequently done in the operating room under anesthesia. Targeted photocoagulation of abnormal vessels, typically in the periphery, is the recommended treatment, and frequently now we'll use adjuvant intravitreal anti-VEGF at the same time as the examination under anesthesia. The slides on the left show an early stage Coats with peripheral vascular abnormalities. The angiogram in the middle on the left shows that there's some remote areas of leakage with otherwise normal appearing vessels. And then the bottom left shows after targeted photocoagulation of the abnormal vasculature, you actually can get resolution of the remote areas of vascular leakage. It's thought that because in the areas of vascular abnormality is where the majority of the VEGF is being stimulated, and so by reducing that ischemia, you can resolve both remote areas of leakage as well as help control the exudation. These slides just highlight a pretty dramatic response to therapy. This is the same patient 6 months, so at treatment on the left and 6 months after treatment on the right. And you can see after target, so this patient underwent targeted photocoagulation as well as intravitreal anti-VEGF. You see complete resolution of the exudation. There was that small serous retinal detachment along the inferior arcade that also resolves, and the OCT shows complete normalization of the foveal anatomy. Management of late-stage coats is more of an open question. There have been some groups advocating for surgery to help preserve the globe. Importantly, if there's any concern for retinoblastoma, you want to make sure you do not go ahead and do surgery, and you'd want to consult with ocular oncology. But several groups have shown that patients who do undergo drainage of the subretinal fluid, reattachment, and then endolaser photocoagulation can do quite well, avoiding neovascular glaucoma and therefore able to avoid enucleation. Dr. Villegas and Dr. Berrocal reported a series of 24 patients with exudative retinal detachment, 83% involving the fovea. Rather than go into surgery, all of those patients received targeted photocoagulation, intravitreal bevacizumab, and none of those patients, notably none of those patients, went on to develop NVG, neovascular glaucoma, or required enucleation. So, it shows that in most cases you can avoid surgery. In cases where globe preservation where surgery is required for globe preservation, this would be a typical case, courtesy of Dr. Villegas and Patel. We have a total exudative retinal detachment, B-scan showing the same without mass or calcification. The subretinal fluid is drained through a sclerotomy. You can see the cholesterol in the fluid. The retina is attached. Vitrectomy is performed. And then endolaser to the abnormal vasculature. In any case where surgery is performed, it's always important to send the samples to pathology to make sure that you aren't missing retinoblastoma or any other pathology. So this is a Papanicolau stain showing red blood cell debris, polymorphic neutrophils, as well as a lipid-laden histiocyte. Here, higher magnification showing the histiocyte. Notably, there are no small round blue malignant cells suggestive of retinoblastoma. And then a CD68 stain confirming the identity of this cell as a histiocyte. So open questions regarding coats. So is there a genetic basis? It's a congenital disease in otherwise healthy individuals. So is there a genetic basis for the disease? And why is coats a unilateral disease? If there's a congenital condition causing vascular abnormality. Some have posited that it could involve somatic mosaicism, given that it's unilateral and there are no systemic abnormalities. It's thought to potentially involve genes that are linked to systemic angiopathic conditions. However, because of somatic mosaicism, it's localized only to one of the eyes. Candidate genes include NORI, which is a Wnt signaling ligand for frizzled 4. Frizzled 4 is the gene responsible for fever. And so the thought is if you have one of these genes, if it's inherited, you'll have systemic manifestations. But if through somatic mosaicism, it's only the abnormal genes only in certain tissues, including one of the eyes, you can have a Coates phenotype. There have been a few studies recently, however, that have shown that there are some contralateral abnormalities in the vasculature in patients with Coates. So this group showed, they did a study of normal pediatric retinas showing that there was 0.9 disc diopters of temporal non-perfusion in normal children. And then over 60% of their sample of patients with Coates had over 2 disc diopters of temporal non-perfusion without any structural abnormalities, suggestive that there might be subtle differences in the contralateral eyes of Coates patients relative to typical patients. And a large international multi-center study recently performed with Dr. Berrocal showed in 176 patients with Coates, about 20% had significant abnormalities in the fellow eye, including aneurysm, telangiectasia, non-perfusion, and leakage. But over a 25.2 month average follow-up, no progression was seen of these lesions, suggesting that it's very unlikely to progress to bilateral Coates disease or to require treatment. So back to our patient, once we called Dr. Berrocal, he underwent examination under anesthesia. He had angiography-guided photocoagulation of the ischemic temporal retina, intravitreal injection of bevacizumab, and referral to pediatric ophthalmology, given the finding that he had anisometropia. And with the normal fovea on the OCT, as well as a lack of foveal exudation, it was thought that perhaps his reduced vision could be related to the anisometropia, and we wanted an evaluation for amblyopia. He rescheduled his appointment, so we don't have the results of that just yet, but he should be following up soon with Dr. McEwen. So this is a recent case from the literature of a patient with Coates with concomitant anisometropic amblyopia. It was a 10-year-old boy found during routine eye screening with Coates disease of the left eye. On cycloplegic refraction, it was shown that he had anisometropia, and he underwent treatment for the Coates disease, as well as then daily patching for the right eye. The initial best corrected visual acuity was 20/50, and at 2 years of daily patching of the non-amblyopic eye, the vision in the left eye improved to 20/25. So some learning points from this case: it's very difficult to evaluate a 4-year-old. This patient had recently been seen in an emergency room, had an ophthalmic evaluation, and the diagnosis was missed, especially when there's lack of macular or foveal pathology or prominent macular or foveal pathology. The importance of evaluating thoroughly for coexisting conditions. This patient could be treated thoroughly for the Coates disease, and if anisometropia was missed, they could still have a poor visual outcome. The critical findings that are different between retinoblastoma and Coates disease, as well as how to distinguish between them clinically, and then the management of early and late Coates disease.